The next thing we're going to focus on is some upper GI concerns. And the first one I want us to talk about is hiatal hernia. If you look at the picture, you'll note the green line in here. This is the diaphragm. The diaphragm separates the thoracic from the abdominal cavities. It's a strong muscle that goes across here. Now, there's a hole in this diaphragm where the esophagus comes down through. The lining of the stomach is impervious to acid. In other words, if you were to focus on your stomach right now, you can't feel the acid in your stomach. Well, if you can, go see a doctor, you've got an ulcer. But most of us can't feel the acid in our stomach. You don't know that the pH in your stomach is probably 1 or 2. Now, the cells in the esophagus cells don't do that. They're not protective. So the esophagus doesn't have any protection against acid. In some people, this cardiac end, this top end of the stomach, herniates up through that hole in the diaphragm. And when it does that, it brings up acid with it. So the main symptom of hiatal hernia is heartburn. So the patient complains of dramatic heartburn. Now, if we talk about how to manage this, could do surgery, and sometimes that's done. That's usually a last resort. With surgery, if they do the abdominal approach, or, well, put it this way, if they do the major surgery approach, they might go in through the thoracic cavity, and this patient may need chest tubes and chest drainage. Some surgeons are doing laparoscopic surgery for hiatal hernias, and that's much better, and the recovery period is much easier for that. Most patients with hiatal hernias never get surgery. What we simply do is teach them how to live with it. So we tell them, first off, sit up after you eat. That makes gravity help keep the food down in the stomach where it belongs. Secondly, don't eat too much at once. So this is not the time to try and pig out or overeat. So eat smaller quantities of food. Avoid gas-forming foods because that will tend to push it up and make it herniate. So, and avoid carbonated beverages because that will tend to make it herniate. Avoid caffeine. Caffeine makes it harder. If you look at the picture, you note here's where the lower esophageal sphincter is. Caffeine makes it harder for this sphincter to stay closed. And if it's not closed, it's easier for the cardiac end of that stomach to just herniate up through. So we also tell the patient to avoid caffeine. So let's summarize our instructions to the patient. Sit up after you eat. Don't eat too much. Avoid carbonated beverages. No caffeine. So what have we done? We've taken away too much food. We've taken away gas-forming foods, all carbonated beverages, coffee, tea, chocolate. Other than that, they lead a perfectly normal life. We might also have them put a block under their head of the bed so that even at night their head is higher. And this also helps to prevent the hiatal hernia. The next thing we want to look at is peptic ulcers. The term peptic ulcers refers to acid-related ulcers, and there's two types of peptic ulcer. Gastric, which are stomach, obviously, and duodenal, which involve the duodenum. Now, I don't care if you call it duodenum or duodenum, it's the same organ. If you take a look at the picture that we have here, the picture of the stomach, these big blue circles are the most common sites of ulcers. And this one right here in the duodenum is number 1. Close to 80% of your ulcers are right in that region. The second most common site is a gastric ulcer, right in that lesser curvature. Here's the greater curvature of the stomach, and there's the lesser curvature. And this is the second most common site. These others are much less common sites for peptic ulcers. I want to point out for you here that we have alkaline-producing cells in the duodenum, but the first few inches are still very, very acid. So what you have pouring out through the pyloric sphincter into the duodenum here is all pure acid. Now, I want you to imagine something for me. I want you to picture in your mind an open sore. And picture what that would feel like. Just imagine, what would that open sore feel like? Now, throw vinegar in the sore. Ooh! It burns, it hurts. Now, what would it feel like if you were able to put something in there and sop up the vinegar? The pain would get less, wouldn't it? All right, now this is exactly what your patient with a duodenal ulcer does. So, 2 to 4 hours after a meal, maybe 2, 3, 4 o'clock in the morning, when the stomach is empty, all the food is passed out, all that's coming out from the stomach now is acid. And that just gets into that ulcer, and it burns and it hurts. And the patients have learned that if they eat crackers or cookies or dry carbohydrates of some type, it sops up the acid and the pain gets less. So people who have duodenal ulcers will literally tell you that they must go feed their ulcer. When they start getting that burning pain, they go feed their ulcer to sop up the acid. And that works quite well for patients with duodenal ulcers. Now, the pattern of pain is different for someone with a gastric ulcer. That gastric ulcer is much higher. First off, the pain occurs more quickly after eating, an hour or so after eating. And that little trick of eating a little dry carbs doesn't work because you've got this whole big stomach to fill up before you could relieve the pain. So there's much less relief of pain by eating in people with gastric ulcers. Sometimes people who write test items are very concerned about the difference between gastric and duodenal ulcers. Duodenal ulcers, the pain occurs 2 to 4 hours after a meal in the middle of a night and is relieved by food, especially those dry carbs that will absorb the acid. We know that most of our ulcers today we know today that most of the ulcers are caused by H. pylori, Helicobacter pylori, a bacteria. Now, since we learned that ulcers are caused by a bacteria, it's made the management of ulcers much better. We simply give them antimicrobials. So we usually do a triple therapy for ulcers. We do a drug maybe called metronidazole or Flagyl. Now, this drug is a drug that you might remember in terms of being used to treat vaginal infections. There's one thing you must teach the patients when they're getting metronidazole or Flagyl, and that is that they should not drink alcohol. If they drink alcohol, they're likely to end up with an antabuse-like reactions. They'll get very sick to the stomach with that. We usually use a second antimicrobial, and this one keeps changing. Sometimes they do amoxicillin or tetracycline or Biaxin, but some other antimicrobial antibiotic agent. And the third part of the triple therapy is some drug to decrease acid production. So it could be one of those anti-secretory agents like omeprazole, which is Prilosec. Or it could be an H2 antagonist like Tagamet or Zantac. But they usually give some drug to decrease acid production. Sometimes the doctor will recommend they take some bismuth because H. pylori doesn't like bismuth very well. They don't always recommend the bismuth, but frequently they do. Now, they take this treatment for 1 to 2 weeks, and we can cure 97, 98% of people with ulcers that way. I won't even tell you what we used to do for ulcers, but this is the current ulcer management. Now, there are a number of drugs that I want us to talk about. So for the next few minutes, we're going to be talking about drugs. Histamine antagonists or H2 antagonists are used to decrease acids production. Now, you can recognize these because these are all itidines. Tagamet was the first one out, and since then we've had a number of drugs, Zantac, Roxid, Axid, Pepsid, a number of these H2 antagonists. They are now available over the counter, which means that in smaller doses than the physician prescribes, people can self-medicate with these H2 antagonists. A couple of side effects I think you should recall. They can cause confusion in the elderly. That's a biggie one for us. They could cause dizziness and dry mouth. You need to remember that cimetidine or Tagamet is best given with meals, and smoking makes the absorption less efficient. Now, the others, it doesn't seem to matter so much about the meals, but Tagamet should be given with meals. Now let's look at antacids. Antacids bring the pH of your stomach all the way from that 1 or 2, which is the normal acidity, up to 3 or 3.5. Now, they're still not making it an alkaline stomach. They're just making it less acid. Some of the antacids you should be familiar with. Milk of magnesia, things that contain magnesium. Now, the side effect of magnesium-containing antacids is diarrhea. After all, milk of magnesia has a laxative effect. Aluminum-based antacids, such as Amphigel, their side effect is constipation. Aluminum can also bind phosphates. This is appropriate if the patient is in renal failure. And so aluminum hydroxide gel is very good for patients in renal failure because it binds the high phosphates. For other people, this can be a problem. Remember that calcium and phosphorus are always in inverse relationship to each other. So if your serum phosphorus is down, your serum calcium goes up. Now, where does the calcium come from to get into the bloodstream? It comes out of your bones. And so if you take long-term aluminum-based antacids, you're weakening your bones. This I could not recommend as a long-term practice. It causes osteoporosis. Now, there are combination-based antacids, and these have both aluminum and magnesium. They're supposed to not give you diarrhea or constipation. We also have sodium-based antacids. The side effect or the problem with these is that they can retain fluid. Now, think for a moment, are there any people that should not take sodium-based antacids? Sure, people with high blood pressure, fluid retention, congestive heart failure. And an awful lot of people will go to the kitchen cabinet, take out the box of baking soda, put a teaspoon in a glass of water, and maybe put in a little bit of lemon, and they've got themselves a nice antacid drink. But this should not be done by people with high blood pressure and fluid retention. Calcium carbonate is another type of antacid, a preparation such as Tums. Now, and it works very well as an antacid. I'll give you a word of caution about this. If you're doing an emission assessment and a patient says that they take Tums every day, ask them why. Because many people take Tums not as an antacid, but as a calcium supplement. It's a much cheaper form of calcium than buying some of the other calcium products. And it comes in pretty colors and flavors. So if you're doing an assessment, they say they take Tums, ask them why. Don't just automatically assume that they have an acid stomach. Another category of drugs we need to take a look at are the GI anticholinergics. These are drugs like belladonna and banthine, probanthine. These can be used for patients with ulcers, patients with irritable bowel syndrome, patients with ulcerative colitis. They slow peristalsis. Now, the side effects of these drugs, red hot, dry, blind, mad. So they cause flushing and warmth. Some people say red as a beet, hot as a hair. Dry as a bone, they make your dry mouth. Blind as a bat. Now, they don't totally make you blind, but they do with the pupil dilation, you can get blurred vision. And Mad as a Hatter doesn't mean angry, it means confused, like the confused Mad Hatter in the movie Alice in Wonderland. So red hot, dry, blind, mad are your side effects of your GI anticholinergics. Another group of GI drugs are anti-secretory, and these are drugs like omeprazole. Prilosec is one name of those. You ought to take these before eating, and they're certainly not safe for nursing mothers. Another category of GI tract drugs are sucralfate and carafate. What this drug does is it's a binding or a coating agent, and it binds to the ulcers. It coats the lining of the stomach, and it coats the ulcer and allows it to heal. Unfortunately, it coats everything. So if a patient were to take another medicine at the same time, it would coat that too, and it wouldn't be absorbed. So you need to wait at least 2 hours or take other medicines 2 hours before they take sucralfate. But please make sure that they get it before meals. Wow. This next piece that we're going to look at is extremely important. So this is one of the few things I tell you you should really be sure you know, memorize, if you will. Because I think they've had questions on the test where they will give you 2 or 3 of these drugs and ask you in which order you give them. So sucralfate and omeprazole are given before meals. Tagamet is given with meals. And the antacids are going to be given after the meals. So I think I would know that sucralfate and omeprazole before meals, Tagamet with meals, and the antacids after meals. Now, if we look at this next picture, this really pretty much summarizes what we've talked about with ulcers. We talked about an endoscopy, that would be your EGD we talked about, upper GI series. Now, we didn't talk about how you diagnose Helicobacter, and we can do that one of 2 ways, either a blood test or a breath test. With the breath test, we know that the bacteria, H. pylori, when it comes in contact with certain chemicals, actually puts off a different gas. So what they do with that one is they take a sample of the patient's breath, then they give them this chemical tablet to chew, and then they get another sample of the breath to see if there's more of that particular gas. Some doctors can actually do this test right in the doctor's office and diagnose it rather quickly. We've talked about the drugs. Now the diet we haven't addressed. Generally, the diet for people with ulcers is frequent meals, particularly for those people who have duodenal ulcers. So they'd be much better off with 6 small feedings a day and relatively bland foods. Caffeine, alcohol, and spices aggravate ulcers. So, but I know that one man's spice is another man's bland. And we really have to tell a patient, if it bothers you, don't eat it. And it's hard. Patients simply do not want to give up things that taste good, even if it causes their stomach to burn. Now, smoking also aggravates ulcers, and stress can. Even though we know that most of your ulcers are caused by bacteria, by H. pylori, there's no doubt but what stress plays a role. We all have H. pylori in our system. However, if you have any kind of break in the mucosa, any change in your chemistries in there, then the H. pylori say, oh, good, I have a place to go and live, and they go and they crawl in there and they multiply and grow and cause an ulcer. So undoubtedly, stress still plays a role in the development of ulcers. Now let's look at a question. An adult is admitted with a 3-day history of severe burning pain in the left epigastric region. Blood pressure is 138/64, pulse 92, respiration 16. Which question will reveal the most information about the source of the client's pain? 1. How long does the pain last? 2. Does exercise bring on the pain? 3. Do certain foods bring on the pain? Or 4. When does the pain occur? So we're asked which reveals the most information about the source of the pain. And the best answer would be number 4. When does the pain occur? This will help to separate whether it's a gastric ulcer or a duodenal ulcer. If you are also wondering, could it be cardiac versus GI, that question will give you that information as well. So when does the pain occur is the best, will tell us the most. Another question for us. An adult who was admitted with a bleeding gastric ulcer complains of sudden sharp abdominal pain. What is the best initial nursing action? 1. Administer the ordered pain medication. 2. Feel the client's abdomen. 3. Notify the physician. 4. Assess for nausea and vomiting. So the first thing we have to do is think about what could that mean? Bleeding, gastric ulcer, sharp abdominal pain. And the most likely cause of sudden sharp abdominal pain in this patient is likely to be a perforation. How would you know if it's perforated? The perforation is going to cause a rigid board-like abdomen. So the very first thing you could do is gently feel the client's abdomen. If it's rigid and board-like, this suggests perforation. So that was the answer to the question. Now, once you have assessed that abdomen, the next thing you do is call the doctor. But if you call the doctor before you touch the abdomen, the first question out of the doctor's mouth is going to be, is the abdomen board-like? And you say, doctor, I forgot to check. No. So how long does it take to feel the abdomen? Seconds. So that's what you would do initially. All right, now we want to talk a little bit about gastric surgery and removal of all or part of the stomach. When we talk about gastric surgery, years ago we used to do a lot of surgery for ulcers. Not so much anymore because we cure them all with antibiotics. So very often the surgery where they remove part of the stomach might indeed be surgery for cancer, for instance. Now if you take a look at the picture there and you see the stomach, you see a kind of a wide top end and the pyloric area is narrower. It's probably even narrower than this picture makes it look. If you were to take out the middle part of the stomach, that wide top end simply does not fit. So they can't just hook it back up. So what they're going to do is to take that wide top end and attach it to the small bowel, probably the duodenum. So what we have here is, here's where your duodenum starts. They're just going to close that off. Leave the duodenum out there because it's got nice alkaline and juices that are being produced. And now the stomach attaches here to the duodenum. Now, if we think about what happens normally, when you swallow food, normally it goes out of the stomach into the duodenum. And as it does, little messages get sent over to the pancreas that says, hey, pancreas, got food coming out. And this food comes out in little glurp, 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 so little bits at a time. The messages go to the pancreas, got food coming out. How about giving us some of those good digestive enzymes? And oh yes, we need some insulin too to help digest this food. All right, so normally it goes out little bits at a time and those messages go to the pancreas. Now imagine what would happen if we have the gastric surgery. So the stomach is attached to the duodenum. Now the food goes whoop all at once. And you've got this huge amount coming out whoop all at once. The message goes to the pancreas, and the pancreas says, wow, if this is the first glurp, imagine how much enzymes and how much insulin you're going to need. So the pancreas secretes huge amounts of insulin. And what this does, if you look back at the picture, you'll notice that about 2 hours after eating, this patient begins to get cold and clammy and irritable. These are signs of hypoglycemia. So they get hypoglycemic because the pancreas has oversecreted insulin. Now they also get the nausea and dizziness because there's been a rapid fluid and electrolyte shift. So we need to do something to alleviate these symptoms. And what we have found out that we can do to alleviate the symptoms is to alter the diet. We give them a diet that's relatively low in simple carbohydrates. That will reduce the amount of insulin production. We give them a diet that's higher in complex carbs and protein. That's so there's something for that insulin to act upon. Now we also usually make it a low sodium diet so we can reduce those fluid and electrolyte shifts. Now you don't want to give fluids with the meals because that makes it go whoop even faster. And lay the patient down after a meal. And that will reduce the gravity pull and the force of the rapid emptying of the stomach. Now, it takes, eventually this patient's body will learn and the pancreas will figure it out. But it can take 6 months or a year for the body to adapt to this new change in its anatomy. So in the meantime, we have to use that dumping syndrome diet that we just discussed.